Hi, my name is Megan Coffey, and I'm going to be speaking about our work on mpox and computer vision for the detection of mpox lesions. So, going to first talk about the fact that this is really a use case, an important example of understanding what we need to know in order to have AI, machine learning work for emerging infectious diseases in low resource settings. Mpox, as we know, is a disease that has been endemic in areas for over 50 years, obviously much longer. And it then spread suddenly in 2022 in new populations, new body parts, ages, skin types, images that were quite different than seen before. And it crossed many borders before we actually identified mpox. So we really need to make sure that we're able to identify this soon. There's clear infection prevention control reasons why you want to identify this disease, and you will need to have better tools to be able to identify diseases like this quickly. And so some of the issues that have come up is that we really want to use AI for this early pattern recognition before clinicians are familiar with the disease. They may overlook certain presentations. They may not recognize classic presentations. They may not recognize less common presentations. The fact that this disease presented in very different populations instead of children in Central Africa. It was among men who have sex with men in Europe and Asia and the US and other parts of the Americas. It's going to be something that we need to make sure that AI models are recognizing these patterns quickly. Then we need to recognize that as a disease spreads from one population to another, there's going to be model and concept drift. Initial populations and presentations may not be represented well in later outbreaks. Maybe a very different model. You may have a decreased degradation in your accuracy. And then also understanding you're always dealing with the fog of war and early outbreaks. So you want to develop tools as soon as you can, but not sooner. You want to have it before you have all the data available, but you want to recognize that if you make a model too soon, it may not be effective. It may be really biased by the initial populations. So what we're really looking at here is a lot of times in AI and healthcare, we focus so much on the algorithm. But there's two other sides to looking at these models as you develop them. There's both the data and the clinical usage. So our hope is to really have a program where we're involving those working on the algorithm, collaborating closely with those working on data, along with those working on clinical use, because it really needs to be answering a question that clinicians have and that will change clinical management. And we also need to take into account that there's been a history of bias in a lot of these models because a lot of data sets on dermatology had only a small percentage of their data labeled by the Fitzpatrick skin type. That's the colors of the emojis. So whether someone's light skinned or dark skinned. And oftentimes it's only about 2% are people of color in these data sets, which when we use transfer learning to work from one data set to another, we may not have models that accurately represent or work with these other different populations. So we worked on having an mpox data set. And just to know, here I'm talking about skin type, but as we've worked on this, we've realized that so much of the issue is actually, what is your image quality? Do you have the same image quality in Africa? Do you have the same image quality in past data sets? But also taking into account that you're going to have lesions that were on fingers in small children initially, but maybe genital lesions. What gender, what sex, what age, what comparator diseases? Are you just comparing this to measles, or are you comparing it to diseases that the clinicians may genuinely be confused by? And so there's a lot of these issues when we look at the data sets and the images that were used in our data and in others. So trying to make sure we account for the stages. Many images focus on the later stages, the pustules, the ulcers, but not the macules or papules, which may be the presentation for the first week. This is an infectious disease. This is a disease that can spread in healthcare settings to healthcare workers. We want to identify this quickly before it spreads to others, particularly if it's new in a community. And so we've really thought about the data set representation. We have two data sets, mpox and not mpox, 50,000 images total, although we have more comparator diseases than mpox disease images. And we also have metadata on their age, gender, sex, body part affected. And then we've really worked with clinicians to make sure these images were curated, were labeled by stage, and that we have relevant comparator diseases so that it represents a lot of these low resource settings, diseases that will be seen, that may not be seen in New York City, but may be seen in Goma, DRC. And so we've really tried to make sure this accounts for these issues. And so the AI and emerging infectious diseases in low resource settings, we're really trying to combine computer vision, pattern recognition can identify mpox images with the additional data that we also have, making sure it's carefully biased. Most people who are represented in most image data sets are male. So if you include male as one of your data set, features, you may have 98% of mpox images being male, can bias your results. So thinking about that carefully, you want a lightweight model so it works on Android phones in low resource settings. We wanted to have no cloud for real privacy. So we're working in areas that are disrupted in terms of governance. M23 Rebel Group went into one area where we collaborate with in the DRC and Democratic Republic of Congo. We work in other countries that have laws that ban same-sex relationships. So we really need to have this data not be going to a cloud. And we also want to think about rapid screening, but know that it's screening. AI can quickly upskill healthcare workers and have task shifting, but we need to make sure that we have confirmatory testing, that we have experts, and understand this concept of model drift. So our data pipeline and architecture, Anish.
Okay, so now I will present you with the end-to-end data model and pipeline we built for the combining workflows with MedGemma. This diagram gives a high-level view of how data moves through the pipeline. It visually shows the path from sources all the way to prediction outputs and how each component is connected to in a continuous flow. Next slide, please. Okay, so like here is the detailed breakdown of their data pipeline. We begin with data ingestion, which collects images and metadata securely from sources. Next, the pre-processing, where data is normalized and enhanced for model consistency. Then the proposed data goes into the model training, where our model learns lesion pattern and associated clinical information. And during deployment, inference and output generates the prediction. Finally, the feedback loop uses the real-world performance and review to continuously refine the model. Next slide, please. Okay. So this diagram illustrates how MedGemma is fine-tuned. You can see how the pre-trained base interact with multimodal inputs and adapted layers to produce mpox-specific predictions. Next slide. This slide summarizes the architecture behind MedGemma fine-tuning. We start with a pre-trained foundation, giving a strong general representation. We then introduce a specialized dataset of mpox and non-mpox lesions with metadata. Through architectural adoption, we adjust key components like vision encoder and LoRa layers to focus on a disease-specific lesion cues. And finally, iterative refinement allows us to train, evaluate, adjust, and repeat until we reach strong diagnostic performance. And to conclude, the combination of secure pipeline and carefully fine-tuned MedGemma model allows us to build a reliable AI-based mpox detection system. And yeah, now we move to data analysis. Twishaa.
So over here we see different distributions. Now we've used these different distributions related to demographic or anatomical distributions to not just highlight the diversity of the data set, but also because metadata is vital in multimodal models. These integrate image features with clinical context, leading to better lesion interpretations, which also reduces biases across different skin groups, different genders, age distribution. So we can see that we have an age distribution, image distribution graph, and as well as gender distribution graph. Um, Going to the next slide, we can also see that we have different Fitzpatrick skin type distributions as well as the body type distribution. Now, moving forward to the results in comparison. In this section, we'll first see our model's overall performance and how it will be behaving in the subgroups. We can see that we've achieved an accuracy of 92%, a precision of 91%, recall of 92%, as well as F1 score of 92%, which is a really good performance. And in the next slide, we can see the confusion matrix. The confusion matrix shows the model correctly identifying mpox and non-mpox cases with relatively false positives and few false negatives. We can also see the performance across different demographic and clinical subgroups. Over here, we see that we're comparing a per class performance between mpox and non-mpox, as well as we've had a Fitzpatrick skin type comparison for each type, and as well as for each gender to understand if there's any underlying bias, which we see that there's not, and MedGemma has been able to generalize and perform well on each subgroup, demographic and anatomical. Moving forward, we also have done the benchmark comparison where we've compared it with existing benchmarks, and MedGemma has been able to outperform all prior CNN-based approaches. And we see an increase of 1.86 accuracy improvement over the strongest previous model, which is the mpox VLM. The F1 score is even larger and more than 6%, which is very meaningful for a diagnostic system. And overall, MedGemma sets a new state-of-the-art for mpox lesion classification. Over here, we've added the graph where we've compared all the models.
Thank you. And I just want to say that this is all part of work to actually implement a outbreak response with International Rescue Committee, working in the Democratic Republic of Congo with a handheld smartphone model. And so, as you know, we've looked at the accuracy, the efficiency, and we really want to make sure that this is a lightweight model and hope that this can be really a foundation for broader infectious disease, emerging diseases, and low resource settings, and that we will, with the IRC and also TCAI, continue to collect real comparator data and make sure it matches the real data that will come from settings so that this will be an effective tool. And that's really it. Thank you.